So, first off, thanks for inviting me here. Like Dr. Henke said, I'm one of the research residents at the University of Michigan. I'm a general surgery resident there, and have spent the better part of my residency looking at appropriateness, in particular with atherectomy. And so I want to share some data from a couple of studies that Nick and I and Dr. Henke and others have published. So I have no disclosures. And so some of this may be a little bit of a repeat for those of you that were at the Michigan American College of Surgeons meeting, but bear with me here. So as you guys are well aware, endovascular techniques have allowed for patients to be treated in the outpatient setting, and this is thought to come with a big cost savings. In fact, in 2008, CMS made some payment policy changes to try to incentivize providers to shift their care from the inpatient setting to the outpatient setting. And that was done thinking that they would come with it a big cost savings, not having to pay for the inpatient stay and all the things that come along with that. But this payment policy was actually evaluated in this paper by Jones et al. In 2015. And what they found was that there actually wasn't a cost savings at all. And it wasn't because people just did more peripheral vascular interventions, but rather was because there was a shift in the procedures that were performed. In particular, there was a 2.5-fold increase in office-based atherectomy. And so we'll talk a little bit about payment incentives around atherectomy, but I'm sure most people on the call are also aware that outpatient or office-based laboratory atherectomy pays significantly better than the ambulatory surgical center or the inpatient setting. And so our question first was, what degree of geographic variation exists in payment for overall peripheral vascular interventions in the outpatient setting? And then does variation in office-based lab utilization explain the variation in Medicare payments for PAD treatment? So our data source for this first part of the talk is the CMS provider utilization and payment data public use file. This is data from really the last 4 years that were available, 2014 to 2017. And our outcomes were rates of and then payment for peripheral vascular interventions per beneficiary. And we looked at a couple geographic breakdowns, but the one I'm going to focus on in particular is hospital referral regions. So overall, this is a set of data that just looked at the national rates and costs of peripheral vascular interventions in the US and break down by procedure type. So on the left side, you can see rate as a function of per 100,000 Medicare beneficiaries. And overall, there wasn't a lot of difference across the time period in total peripheral vascular interventions, which is this line up here. But we did see a steady increase in the use of outpatient atherectomy. And in particular, this was associated with a decrease in stent use. Now, what's particularly interesting is that when we look at the total payment in thousands of US dollars for atherectomy or the rest of these procedures over that 4-year period, you can see that the total payment for atherectomy almost directly mirrors the total payment increase over that time period. So that is clue number one, and that's sort of getting the horse in front of the cart here a little bit, but generally speaking, the rest of the talk mirrors that data. So first, we wanted to look at hospital referral regions. These are regions that are commonly used for assessing referral patterns within the US. In particular, they represent tertiary referral patterns for geographic regions across the US. And what we found was that there was significant differences in the way that payment changed over the 4 years of the study. So you can see that there was some regions that actually decreased their cost per beneficiary over the 4 years, but there are actually some that dramatically increased their cost or their payment over that period. So with that, our first question was, is this geographic variation correlated with strictly increased rates of peripheral vascular interventions in those geographic regions? And what we found was that the answer is no, not particularly. So we did see a low correlation, about 0.40. And you can see here, this is basically that same map that I just showed, changes in payment over that 4-year period. And the bottom is changes in the rate of total peripheral vascular intervention. And there's not a lot of overlap. And so each of these dots corresponds to a different hospital referral region. And so the take home from this was that, yes, some of these regions are doing a little bit more in terms of peripheral vascular interventions, but it's not explaining the majority of the variance that we're seeing. The second question was, is the change in payment that we're seeing correlated instead with OBL utilization? And so again, this top map is changes in payment, the same one I showed at the beginning. And this bottom one is changes in the use of office-based labs for peripheral vascular interventions. And what we found was that there was a direct correlation. Almost the entirety of the variance in cost for peripheral vascular interventions in the outpatient setting in the US can be explained by increases in the use of office-based labs for PVI. Now, there's lots of things we can do in the peripheral vascular lab. And so the question then is it atherectomy in particular, or are we using stents more, et cetera, et cetera? And so what we found is that, again, atherectomy alone in the office-based lab actually explains 85% of the increase in payment change per beneficiary across these referral regions. So to us, that was pretty striking. I think really drives home kind of what we found and what other groups have found in terms of atherectomy, the sort of explosion of atherectomy in the office-based lab setting. And I think mirrors what we've heard from leaders in the field as well. So I think we kind of showed that office-based lab utilization has exploded over the last really decade, but even more so in the last couple of years. And so our question then became, what characteristics define these patterns of utilization amongst those who actually perform atherectomy? And so there's unique aspects of billing for atherectomy from both private payers and from public payers, in that atherectomy or outpatient lab procedures, you can actually bill multiple interventions. So you can submit multiple CPT codes per patient, per vessel, per bilateral procedure, et cetera, which is a little different than how we bill for other procedures in the surgical world. And so we wanted to know, are there differences in the number of patients? Are there differences in the number of vessels that are treated per patient? And are there differences in the number of catheter deployments for atherectomy across people who perform a lot of atherectomy? And so we used, we've been talking a lot about BMC2. We talk about data from the Michigan Value Collaborative, which is another CQI that Blue Cross funds. And we used basically all claims through this Michigan Value Collaborative, which contains data from Medicare fee-for-service professional claims data, as well as Blue Cross Blue Shield claims data. And we only included people that did both greater than 20 OBL atherectomies and saw 20 new patients per year. And we used data from 2019, which is the most recent available. Our outcomes were total professional payments. We're interested in the conversion percentage, which is sort of the proportion of patients that the proportion of new patient evaluations that went on to receive a procedure, the mean number of vessels per patient, and the mean number of treatments per patient, or catheter deployments. And this is all done at the provider level. So we found that there were 59 people in the state of Michigan that met these criteria. And there's dramatic variation across those 59 providers and the total professional bill for atherectomy, in particular in the office-based setting. So you can see there's a big chunk of people that do, relatively speaking, lower volume atherectomy and billing, but there's about 9 people that bill. So one provider in particular billed almost $7 million alone for office-based lab atherectomy in the year for 2019. So then we wanted to know, again, like I mentioned before, are these providers converting more patients? And the answer is yes. There's about a 40.47 is the R squared here. And you can see that there is essentially a direct correlation between the conversion percentage and the total professional bill for atherectomy. Additionally, we found that people who bill more for atherectomy also bill for more vessels treated per patient. Again, similar p-value greater than or less than 0.001. And then finally, we looked at number of treatments or catheter deployments per patient. And again, we found the same correlation. And so all these things kind of point to some of the mechanisms by which high utilizers are achieving this high reimbursement rate. So they're converting more patients to atherectomies, they're treating a higher number of vessels per patient, and they're deploying the catheter more times per patient. And so I think from a quality improvement perspective, these all represent possible levers that we can use from a policy perspective to try to modulate the utilization of atherectomy to try to be more appropriate across the US. This is one final slide that I'll drop in here. There's been a lot of discussion about who should receive atherectomy and who shouldn't. And I think that there's still a lot of controversy in this space, but certainly the data that we've found, which most compelling, which is from this paper from Ram Kumar and the Journal of the American Heart Association 2019, used study design called an instrumental variable analysis, and really showed that atherectomy compared to stenting may actually not be benefiting our patients for the majority of the time. And I think that really drives home the point that we as a society don't have a great understanding of who actually benefits from an atherectomy. And so it really kind of underscores the appropriateness of atherectomy overall. That'll take any questions.
Thanks, Greg. I don't know if Nick has any comments as senior author. Thanks. I think we welcome kind of a robust discussion about this either now or as the rest of the meeting goes on today. I think it fits in the big question of how we best define how to treat patients. And I think this is really interesting data that we've shared about kind of the overall trends in the country, and Michigan is no exception to that. When you look at the data across the state of Michigan for the adoption of atherectomy and office-based labs, especially, it does make you wonder, why there's such variation in the absence of really compelling data that atherectomy is superior to everything else. If someone has that data, I'd love to see it, but I just have not seen that yet.
Sorry, Nick, I Louis here. I joined late, and so I guess my two comments is, I guess my two comments on this is, I rarely use atherectomy, maybe once or twice a year, but when I use it, I really need it because I have a very calcified vessel. And I guess the question is how do you regulate that's being used on the appropriate vessel? I do not know, because there is an indication for its use, I think.
Yeah, no, I agree with that. I'd say I probably am. I'm like you. I use it a couple times a year, and I do a lot of peripheral interventions. But in terms of whether I need to use atherectomy versus traditional angioplasty or stenting, I think I just haven't seen the data to say that I really need to do it. I use it in those ones you can't even track a balloon over, when you need to just get a channel to get down there. But I think the question is how you regulate it. Unfortunately, in the United States, it seems like the only way we really regulate this stuff is with reimbursement. That's how we got renal artery stenting to really not be as much of an epidemic as it was at one point when you had drive-by renal interventions. How did that change? It wasn't that we saw better data, it was that CMS changed the reimbursement for renal interventions. And so,
Nick, if I can make a couple of comments, is Krishna. My talk follows yours, so they'll touch on a couple of things, but a couple of things that are missed in this discussion and all the papers that have been published about atherectomy is, one is the cost of the atherectomy. Because if you look at the CPT codes, if you look at an angioplasty stent, and if you look at angioplasty and atherectomy and stent, usually the atherectomy code will pay you about $3,000 more than if you just do an angioplasty and stent. So one thing that is missed in all the papers that are published is the cost of the atherectomy catheter. The cost of the atherectomy catheter can be anywhere between $1,800 to $3,000, depending on how you have negotiated your price. So yes, it is cost the most to the system, but I'm not sure the profit margin is as big as one would incline to believe because of the high numbers of payments. The second comment I would make is that your graph was very nicely done. If you look at, most of the people follow within a certain range, and there are certain outliers. The question always becomes, these outliers muddy the water and bring a lot of bad publicity to a particular procedure. So how do we deal with these bad outliers? And that has always been a challenge, whether it be fixing AAAs or asymptomatic carotid endarterectomy or whatever. So that is always a challenge that one faces, how to deal with the outliers, because they know they have ways how to fix it. The third comment I would make is that one of the advantages of atherectomy, I'm not saying that atherectomy is there's no comparative data. I'll talk a little bit more about in my talk. But one of the advantages is that with a stent, it does decrease the number of stents you put in after atherectomy. And in-stent stenosis continues to be a major problem. All of us deal with it. I mean, a year, 2 years down the road, they come back with some stenosis and then you fix it. So the question is atherectomy cost worthwhile up front to decrease the degree of in-stent stenosis going forward? That question has never been answered. It can only be answered by a comparative study, but no company is willing to support their study because it costs a lot of money to do that.
I can talk about the first two questions. I appreciate the comments, and I totally agree. I think the data that we have would suggest exactly what you're saying, which is that the majority of people, in fact, almost 90% of the providers that we found in this study have a relatively speaking, similar reimbursement across patients and between stenting or atherectomy in the office-based lab setting. So you're exactly right that those providers in particular bill about sometimes $6,000 more or reimbursed that degree for the office-based lab atherectomy relative to their stent. Now, the other providers in that study have dramatically increased their reimbursement rates to the point where that top biller, the one who billed $7 million alone, actually had a mean reimbursement from Medicare of $27,000 per atherectomy in 2019 alone. And so I think that the way that I approach that is that it actually opens up a lot of levers for change within this group. One is that you're right, we don't actually need to target the entirety of atherectomy utilization because most people are probably using it exactly as has been described previously for difficult calcified lesions, et cetera, you know, as a adjunctive technique when they see a difficult peripheral lesion. I think that what we're doing then is that it actually makes our work easier. We just need to find out who is overutilizing it and curb that overutilization. And that has the potential, one, to be less work overall, and two, really concentrate the cost savings at the state and the payer level, because we can really take care of, you know, 90% of the reimbursement happens for about 8 or 10 people in the state. So I think that those things actually are benefits as opposed to challenges, in my opinion.
Yeah, this, I have to say, Nick and Craig, you guys did a very nice job. And I agree with what Dr. Jain has said. I think that, number one, there is a role for atherectomy. There's no question about it, but it hasn't been clearly defined because as an early adopter of atherectomy back in 2005, I used to use it fairly frequently. And, you know, we basically learned that it looks good in the beginning, but it doesn't last. So you have to be very careful in your patient selection. Then the other comment that I'll make, which is sort of the elephant in the room, is that there is a group who has an office-based lab, and they practice in a way that I would think that the majority of the people attending this conference would think is ethical. And I'm talking about bringing a patient in who has claudication and treating each tibial vessel at a different sitting. And the average patient gets 8 to 10 procedures done. I think that that's unethical. And again, you'll find this by looking at the billing and the submission of bills to the insurance companies. And I think there has to be a way for us to say that this is unethical and that these people shouldn't be practicing. Maybe the Michigan Vascular Society could start something and, you know, like a whistleblower type of thing.
Yeah, Ash, I 100% agree with your comments and Dr. Jain's comments. I think Craig did a nice job kind of replying. I don't want anyone to interpret that we're anti-atherectomy or anti-OBL. I think we just are trying to point out the kind of the problems with kind of how it exists right now. And I think there are these bad apples that make it bad, that will at some point make it bad for everyone, right? You know, if they continue to bill $26,000 per session, at some point you're going to see it affect everyone in terms of reimbursement. I think as a society and, you know, vascular providers have to at some point stand up and say, look, we need to do something to change that behavior. You know, maybe that means advocating for some type of capitation, right? Maybe you can't bill for $26,000 worth. Maybe it capitates at some point. Maybe we do have to have more regulation of our own specialties to prevent people from doing these things. But the problem is, as you know, these aren't all necessarily vascular providers. The people we're talking about aren't people on this call. And how do we actually have some kind of stick, you know, or better would be a reward to keep them from doing it. You know, how do you reward the good behavior and dissuade the bad behavior is a huge question in how we've set up our fee-for-service system.
Yeah,
I'm going to touch on that a little bit, Ash and Nick. Nick, you guys have done a great job of publishing your articles. So I'm going to touch on it, my talk a little bit as to what I think could be done to fix this problem.
Well, so let me tell you, I don't know how many times you folks do this, but at least once or twice a month, I have to call a physician to authorize a CT scan. and I have to talk to somebody who's not a vascular surgeon, who's some retired, I'm not going to disparage anybody, some retired person somewhere who's working for an insurance company and is asking me why I'm ordering a CT scan on a patient. So the last time I asked the guy, so what are your qualifications? How come you know stuff that I don't know?
That's great. I think we do have to take a break, and I know Dr. Jain will be well set for the next session, and why we invited him. Obviously, he's a Michigan Vascular Authority member and participant. I think he'll offer a nice balanced view of this. And so let's all get a coffee or bathroom or water or gin break, whatever you like.